Sometimes, though, these skin cells don't move like they're supposed to. Instead, they clump together, mixing with the sebum created in the oil gland. And the result of this process of skin cells clumping together and mixing with the sebum from our oil glands is what we call a comedo. The term comedo is what we call a single clog, whereas you've probably heard the term comedones before, which is simply what we call multiple clogs. Now notice something here. We never mention dirt when talking about what causes clogged pores. This is the first myth that we need to dispel when it comes to acne. Dirt, in the truest sense of the word, plays little if any role in the formation of acne. The commercials on TV for various cleansers will lead you to believe otherwise, but it's true. Does that mean that we don't want patients washing their face? Of course not. Cleansing can help somewhat in that it helps to remove excess surface sebum, which can have a slight impact on the clogged pore process. But the bottom line is that patients should know that dirt is not to blame for their acne, as parents are sometimes guilty of leading their children into believing that they're just not cleansing enough and are therefore to blame for their breakouts. Within our skin, healthy keratinocytes make a smooth progression from the lower epidermis, gradually working their way to the outer epidermis, at which time they naturally break free and slough off. Occasionally, though, a keratinocyte grows abnormally. Its DNA has been damaged, and it doesn't progress through a normal life cycle like it's supposed to. Instead, it produces clones of its damaged self, which essentially build up on top of each other and create the thickened, scaling lesion that we recognize as an actinic keratosis. So what might cause the DNA to be damaged, or contribute to our body's inability to repair that damage? Beyond right and left designations, there are 5 other main directional descriptors. They are proximal and distal, superior, mid, and inferior, anterior and posterior, medial and lateral, and dorsal and ventral. Ventral is sometimes described as volar, so you may hear ventral and volar used interchangeably. Calcium interferes with the absorption of tetracyclines. They should not be taken with calcium-containing food or supplements at the same time. The medication will tend to bind to the calcium and won't be fully absorbed. So while it doesn't hurt the patient, it does interfere with the effectiveness of the medication. Patients who drink a lot of milk or eat dairy products or who take a calcium supplement should take their medicine 30 minutes before or 2 hours after ingesting calcium. The pharmacy labels on these antibiotics will often instruct patients to take these on an empty stomach. This really isn't necessary. Patients can take them with a meal, just preferably not one which contains calcium. Minocycline is known to cause headache and/or dizziness in some patients. And minocycline has been shown to cause bruise-like skin discoloration in some patients if taken for a prolonged period of time. Those of you who've worked in dermatology for years have likely seen this before. It's rare, but it does happen. Griseofulvin is an older medication which is available as either a pill or as suspension. It's important to note that it's also available in what is called micronized and ultramicronized forms. These other forms allow for better absorption, but they also affect the total dose that a patient needs. When your doctor prescribes griseofulvin, make sure you're clear on which form your doctor is prescribing before you write it down or enter the prescription into the EMR. This is especially important as this is often prescribed for children who have tinea capitis, and treatment for at least 6 weeks, if not longer, is common. In this diagram, we can see how the histamine receptors line the wall of the blood vessels. Well, when we take an antihistamine, the active ingredient will attach itself to these histamine receptors. The histamine receptors are now blocked, and there's nowhere for the histamine to attach, so the blood vessel inflammation that we saw in the last diagram cannot happen. It's worth noting that the H2 blockers, the medicines which are typically marketed for stomach acid treatment, still work in the same manner. The difference is that they block what are called type 2 receptors, which are more common in the stomach. When activated in the stomach, they result in acid production, but these type 2 receptors are also present in the skin. They're just not as plentiful as the original type 1 receptors. There are just enough, though, to cause problems, and simply adding one of the type 2 antihistamines to a patient's regimen can really make a big difference. In an abnormal or autoimmune response, there is no invasion by bacteria, viruses, parasites, or anything of that nature. Instead, the immune system fails to recognize that a given cell or naturally occurring substance belongs to the patient's own body and mistakenly identifies it as a foreign threat. It will, in turn, mount the same type of response, even going so far as creating antibodies against its own tissue. Exactly why this happens, no one knows for sure. Provided the decision is made to move forward with the prescribing of a biologic, all baseline testing, such as tuberculosis and hepatitis screening, blood work, etc., typically must be completed before the medication can be prescribed. The longer a patient waits to have that testing performed, the longer it will take before they can start the medicine. In fact, some insurances won't even consider providing coverage until all baseline testing has been performed. We're going to talk about new patients for just a few minutes now. Let's first define what a new patient is from a billing perspective. A new patient is one who has never been seen by any providers in your office before, or who has not been seen or provided medical care or advice by way of communication such as telephone for at least 3 years. For example, let's say you work in an office which has 3 dermatologists. A patient initially sees one of the dermatologists, but then at follow-up, the original dermatologist he saw is unavailable, and he sees her partner. Even though this patient is new to her partner, he isn't new to the practice, so a new patient code can't be used. In another example, let's say a patient is seen for an initial visit, but then isn't seen again for years. 2 years, 11 months, and 20 days later, she calls the office asking for a refill of a medication, and your doctors approve it and call it in. Even though she was simply provided a refill, that is considered a form of medical care. From that point on, 3 additional years of not seeing her or communicating advice or medical care over the telephone will need to pass before she'll be considered a new patient again. Patients notoriously use the term melanoma very loosely. Many times when a patient reports a history of melanoma, they're mistaken, and what was actually treated was one of the non-melanoma skin cancers, or sometimes it was even just a simple actinic keratosis. Questions you can ask to help the patient clarify this include: how serious was it presented to the patient by the doctor that originally diagnosed it? If the patient reports that he was told that it wasn't serious or there was no urgency associated with its treatment, this would be more suggestive of non-melanoma skin cancer such as a basal or squamous cell. Patients may also express their understanding of skin cancer types in terms of the best kind and the worst kind, because that's how their doctor explained it to them. If someone says they had the best kind of skin cancer, they're usually referring to a basal cell carcinoma, and the worst kind would typically refer to melanoma. Were lymph nodes checked? If a patient had complex surgery in which he or she reports that they checked the lymph nodes, then this almost guarantees that they had melanoma. However, not having lymph nodes checked doesn't necessarily mean that it wasn't melanoma. Instead, it could have simply been an early, thin melanoma or one of the non-melanoma skin cancers. How big is the scar? Although melanoma excision scars aren't nearly as large as they used to be, they still tend to be larger than your typical non-melanoma excision scar. If someone reports an uncertain history of melanoma and then refers to a scar which is very small or hardly visible, then that would call into question the original diagnosis. What did the original lesion look like? When all else fails, sometimes simply asking the patient how the original lesion looked can give you an answer. If someone is reporting a history of melanoma and they indicate that the original lesion presented as a dark mole that kept growing, then their reported history makes sense. On the other hand, if someone simply had a scaly spot which wouldn't heal, while it's not impossible for such a lesion to have been a melanoma, it's much less likely, as the majority of melanomas appear very dark and don't scale. Granuloma annulare almost always presents the same way. A patient comes in who has been treating a given area for what they or their PCP thought was ringworm, but it's just not resolving. And strangely enough, it doesn't itch like they thought ringworm would. And on examination, you notice that there are indeed a number of small papules and annular plaques, but they're not as scaly as what one might expect with tinea. Statistically speaking, steroids are the most common type of medication that dermatologists prescribe. And at least from the patient's perspective, they're also one of the most misunderstood. Did you know that steroid is simply a chemistry term, a way of naming the chemical structure that is seen in any number of chemical compounds? The steroid family includes compounds ranging from testosterone to prednisone, and even cholesterol is considered a type of steroid. Of course, ask the average patient, and they'll think that all steroids are the same. How many times have you been asked if the prednisone that your doctor prescribes will make the patient's muscles bigger? The fact is that anabolic steroids are the category of steroid which change the way our body builds muscle. Corticosteroids, which are what we prescribe to patients, are also in the steroid family, but they have an entirely different effect on our skin and in our body. As you know from our discussions in a few other modules, the immune system is fairly active in our skin, keeping a watchful eye out for any signs of invaders such as allergens, bacteria, fungus, parasites, etc. Within the epidermis, we have something called dendritic cells, which monitor for problems. In healthy skin, unless injury has occurred, the epidermis remains fully intact, and the dendritic cells remain quiet. And part of what allows a healthy epidermis to remain intact is the so-called lipid bilayer, seen here as the yellow color between the keratinocytes, which is something you may recall from our Moisturizers module. It surrounds our keratinocytes, essentially helping to seal out allergens, bacteria, and other invaders from entering the epidermis. The problem is that patients with eczema tend to not have a normally functioning lipid bilayer. Amongst the reasons why, they simply don't produce the same levels of ceramides as those without eczema, nor do their keratinocytes contain a normal amount of natural moisturizing factor. And as we saw in the Moisturizers module, sunlight, harsh soaps, and frequent water exposure all act against the lipid bilayer, resulting in epidermis which is much more prone to cracking and splitting. Even if those cracks and splits are microscopic, they provide an opening for invasion by allergens and bacteria, which are quickly recognized by the dendritic cells that we spoke of just a second ago. Once the dendritic cells are activated, they send out the battle cry, and numerous immune system processes begin, resulting in the inflammation that we see as eczema. To complicate matters further, this is often just the beginning of what turns out to be the vicious cycle of eczema that we mentioned a moment ago when talking about the role that irritation plays in precipitating eczema. Ask yourself how many times you've seen a patient who is stuck in this pattern. The patient's eczema itches, so the patient scratches, which causes additional epidermal breakdown, which allows for increased allergen and bacteria exposure, further increasing inflammation, which causes additional itching, so the patient scratches, which causes additional epidermal breakdown, which allows for even more allergen and bacteria exposure, further increasing inflammation, which causes additional itching, and on and on and on. After being developed originally as a diuretic, spironolactone was coincidentally found to have an affinity for what are called the androgen receptors in the skin. Androgens include hormones such as testosterone, DHEA, DHEAS, and DHT. By blocking androgens, spironolactone is able to prevent one of the driving forces behind conditions such as acne, hirsutism, androgenetic alopecia, as well as others. Hydroquinone works by inhibiting tyrosinase. Tyrosinase is the enzyme which converts tyrosine to melanin. Melanin is the pigment that makes up skin color. If tyrosine can't be converted to melanin, pigment can't be produced, and dark areas become lighter in color. It's really that simple. Just remember that, as a dermatology tech, you don't have to commit to memory the exact mechanism of action of products like hydroquinone. It's more important that you simply understand that fading creams do not bleach the skin as many believe. They interfere with new pigment production, but they don't work like Clorox. It's understandable for patients to believe that, but those of us working in dermatology need to have at least somewhat of an understanding of the science behind these products. Upon very close inspection of scabies-affected skin, you can usually see very small, pinpoint, and erythematous vesicles. What are called burrows can also be seen, if the patient hasn't scratched them away. A burrow is literally the result of the scabies mite tunneling through the epidermis, which is where it lives out its entire life cycle. And like the louse which causes head lice, scabies mites are also kind of scary to look at. Here we see how one appears under the microscope. In fact, they can only be seen under magnification, as they are far too small to see with the naked eye. When patients feel the intense itch of scabies, interestingly enough, it's not the result of the mite biting them, but instead is from the skin reacting allergically to the body of the mite itself. Also, notice one thing in the name. The word homini is used to differentiate human scabies from animal scabies. This is a frequent question that patients will ask. Animals, such as dogs, can have scabies, but their type of scabies is different. It's extremely rare for animal scabies to infect people, as they simply don't prefer human skin. So when a patient asks if their dog gave them scabies, you can assure them that it's very, very unlikely. The first group would be what iPledge refers to as females of childbearing potential. Within the iPledge materials and website, you will often see this group referred to as FCBP. The name seems rather self-explanatory. That is, females who are physically capable of becoming pregnant belong to this group. It literally does not matter if we're talking about a 12-year-old girl, a 20-year-old college student, or a 40-year-old Catholic nun. If a female has a uterus and has the potential to ovulate, iPledge places her in this group. Even patients who have had tubal ligation performed but have at least one functioning ovary and a uterus are included in this group. Even patients who aren't allergic to aspirin should avoid using excessive quantities of salicylic acid creams or lotions. Why is this? If too much salicylic acid is applied topically, it can be absorbed into the bloodstream, where it can cause a condition known as salicylism, the effect of which would be similar to overdosing on aspirin. Children in particular should avoid using more than 2 grams of 6% cream or lotion within any 24-hour period. In adults, the threshold is much higher, but still, to be safe, even adults should avoid using topical salicylic acid regularly as moisturizer for their entire body. Instead, its use should be limited to only the toughest, scaliest areas most in need of its keratolytic effects. It's also worth clarifying to the patient exactly how it is that your supervising physician is prescribing it. In other words, make sure they fully understand the once-weekly dosing method. There is nothing worse than when a patient who has been prescribed a month's worth of medication calls the office 5 days later asking for a refill because they've taken all of their medication, as they misunderstood the directions and have been taking their pills once a day instead of once a week. Another consideration is that physicians also will often recommend folic acid supplementation to be taken at the same time as methotrexate in order to help decrease the potential side effects. It's usually prescribed for 1 milligram to be taken once daily, but your supervising physician will decide exactly how much to prescribe, if at all. Patients should also avoid overuse of acetaminophen, which is the active ingredient in Tylenol, as well as NSAIDs such as Aleve, Motrin, and aspirin products. Your supervising physician will determine just how much of these medications he or she is comfortable with the patient taking while on methotrexate. It's not usually a problem for the average patient that takes either for the occasional headache, but some patients take these quite regularly in surprisingly high amounts, so just be aware of this. Although the primary method by which methotrexate helps psoriasis is thought to be by limiting the rate at which skin cells proliferate, methotrexate also limits the body's overactive immune response to varying degrees as well. Because of this, patients should avoid taking it while they are sick or if they have active infection of any kind. Arguably one of the most important of moisturizing ingredients, at least for patients with conditions like eczema and contact dermatitis, would of course be those which assist in repairing the epidermal barrier function provided by the lipid bilayer that we mentioned a few moments ago. These include ceramides, cholesterol, and fatty acids. To some of you, the word ceramides may look familiar, as they've been increasingly recognized as one of the more important moisturizer ingredients in recent years. CeraVe was the first major manufacturer to place an emphasis on the inclusion of ceramides in their products, though other skincare lines have now joined in. Keloids and hypertrophic scars are discussed together here for obvious reasons. Both usually originate after trauma of some sort. Here we see an image of a keloid on the left with a hypertrophic scar on the right. We're going to use these images to discuss what differentiates one from another. Notice how the keloid on the left creates scar tissue far above and beyond what would reasonably be necessary to repair the wound. It's as if the scar just didn't know when to stop growing. In contrast, hypertrophic scars, such as that seen on the right, similarly create excess scar tissue, but that growth remains within the confines of the original wound. In other words, it's above average scar tissue, but it's not so completely out of hand as that seen in keloids, and it doesn't extend far beyond the margins of the original wound. In the end, they're both approached and treated about the same, at least initially. But it's worth explaining this difference, as many who are new to dermatology, and even some who've been working in dermatology, don't fully understand the difference. There are two primary types of biopsies. The first involves the routine H&E stain, which stands for hematoxylin and eosin. H&E biopsies are the standard biopsies that you're probably used to seeing performed throughout the day, for everything from common rashes to evaluation of suspicious lesions. They get their name from the stains used in the preparation of the biopsy specimen. Hematoxylin stains certain parts of the cell, such as the nucleus, very dark blue, while eosin imparts a reddish-pink color to the other areas. H&E biopsies simply allow the pathologist to examine the overall appearance of the biopsied tissue, but provide little indication of the immune cell activity. On the other hand, direct immunofluorescence, which many refer to simply as DIF, works by highlighting the level and type of immune cell activity within the tissue specimen. When used to test for lupus, you may sometimes hear it go by the name lupus band test, though it's useful in working up many more conditions than lupus alone. Here we see an example in which the fluorescent band represents IgG antibodies deposited between the epidermis and the dermis. Both tacrolimus and pimecrolimus work by inhibiting a substance called calcineurin. The exact manner in which this helps is quite complicated, but just know that by decreasing the effect of calcineurin, these medications help to decrease the overactive immune response seen in conditions such as eczema, contact dermatitis, and seborrheic dermatitis. You may recall from our UV light, sunscreen, and skin type module that UVA penetrates down to the level of the dermis. Well, one of the reasons we don't like for our patients to be exposed to too much ultraviolet light is because upon absorption in the dermis, UVA temporarily inactivates a number of immune processes. While on one hand, repeated and excessive exposure to ultraviolet light can increase our risk of skin cancer, that same exposure, when administered in the dermatology office, can be carefully used to combat the excessive immune activity that occurs in conditions like psoriasis, eczema, vitiligo, and many others. It's all about weighing the risks and the benefits. For example, in the world of psoriasis treatment, the alternatives patients have include either living with the disease or taking medications which can potentially harm their liver or increase the risk of systemic infection. Therefore, relatively speaking, for many patients, the slightly increased risk of skin cancer is one worth taking, especially considering the alternatives. So where then do psoralins come into play? Well, when patients take 8-methoxypsoralin prior to coming into the office, it's absorbed within the dermis, as illustrated here by the green circles. Now, the exact manner in which 8-MOP works is quite complicated and is really well beyond the scope of our program. The main concept that you, and patients for that matter, need to understand is that upon exposure to UVA, the 8-MOP psoralin absorbs and subsequently transfers energy to the surrounding cell structures and DNA. which further inactivates the immune activity, above and beyond what UVA alone can do. So while UVA by itself has the ability to suppress dermal immune activity, Psoralen plus UVA provides even greater suppression. And when channeled carefully through PUVA treatments, this enhanced suppression can be used to limit the immune overactivity seen in conditions like psoriasis, eczema, and vitiligo. Lines and wrinkles are of course the hallmark feature of aging skin. First, you should know that, technically speaking, the proper medical term for a wrinkle is rhytid. It's a term you'll probably hear your supervising physician use from time to time. So with that said, rhytids are the result of skin which has been stretched beyond but then fails to return to its original state. There are two components of rhytids. The dynamic component is that which is due to underlying muscle contraction. In other words, as long as the underlying muscle is contracting, the skin will fail to return to its original state. Think frown lines and crow's feet. Because of the role of muscle contraction, dynamic rhytids can occur in both the very young as well as those who are older. The difference, of course, is that when we're older, the skin isn't as quick to return to its original state, which is where the static component comes in. The static component of rhytids is that which persists independent of any underlying muscle contraction. In other words, these are the wrinkles which were either never influenced by muscle contraction in the first place, or even after the muscles are completely relaxed, they still persist. When tissue is normally submitted to the lab for evaluation, the lab only obtains a number of random samples from the specimen in a manner which is often referred to as being similar to slicing a loaf of bread. The problem with this approach is that sometimes a small extension, which some doctors may refer to as a root of the skin cancer, may be growing from beyond the main body of the skin cancer and get missed by this traditional bread loaf style of specimen evaluation. For example, let's say that for this section, the pathologist evaluates these two slices. If the so-called bread loaf slices happen to be taken just to either side of the thin extension of the skin cancer, then it's possible for the margins to look clear, but in fact there could be a focal area of residual skin cancer that was missed. In contrast, most surgeons will excise the skin cancer by essentially shaving around and beneath it. And rather than taking random bread loaf style slices, they will look at the removed tissue almost as if it were the underside of a pie, even going so far as to map out the various corners of the specimen and evaluating it slice by slice. In this manner, minute extensions of skin cancer that may have otherwise been missed by traditional examination are seen, and there will be much less likelihood that the patient will experience a recurrence of skin cancer in the following years. In psoriasis, the skin cells are pushed out into the world much too fast for their own good. Instead of being given a month or so to mature, the epidermal cells might be given as little as 7 days before being pushed to the outer epidermis. They haven't been given enough time to acquire the strength and flexibility they need in order to serve as healthy epidermal cells. They don't develop uniform size and thickness. They're unable to appropriately retain lipids and moisture, so they quickly crack and become dry and scaly. And rather than sloughing gradually and in a timely manner, they build up layer upon layer, clinging desperately to their mother, except in this case, their mother is the epidermis. Just like children being raised too fast for their own good, they just haven't been given enough time, and they're simply too undeveloped to successfully make it on their own. After activating what are called retinoid receptors in the skin cells, retinoids first affect skin cell growth and differentiation. Second, they alter the adhesiveness of skin cells. And the third major way that they help us is by decreasing sebaceous or oil gland production. We're going to spend a few minutes explaining these because this is a perfect example of why a program like this is so important. Many of you watching this have worked in dermatology for years and have probably helped your supervising physician prescribe retinoids hundreds if not thousands of times. But odds are that no one has explained to you how these very common medications actually work in helping our patients. Let's first explain what we mean by affecting skin cell growth and differentiation. In acne, skin cells inside the pores, because of hormonal influence, can become stagnant, In other words, they hang around for too long, and as a result, they clump together and the pores get clogged with the patient's own skin cells and oil mixture. Retinoids help keep skin cell production moving along, decreasing the time they have to clump together and clog the pores. In sun-damaged and aging skin, skin cell production is also slowed down. The result is that cosmetically abnormal skin cells, which appear dull, have irregular pigmentation, etc., become more visible. This slowing down also allows microscopically abnormal skin cells, which may have some precancerous qualities, extra time to develop and potentially make the transition from precancer to skin cancer. Retinoids keep skin cell production moving along, decreasing the time the cells have to start looking or acting abnormal. Altering the adhesiveness of skin cells helps us as well, in a number of ways. In acne, retinoids help the mixture of skin cells and oil within the pores to break up more easily, helping to unclog the pores. In sun-damaged and aging skin, retinoids help the abnormal skin cells to exfoliate more easily, making way for newer, younger skin cells within the epidermis. And in psoriasis, retinoids help to break the bond between the built-up skin cells, thereby helping to decrease the thickness and scaling of psoriasis plaques. Decreasing the sebaceous or oil gland production is the third manner in which retinoids help us in treating certain dermatological conditions. In acne, sebum feeds bacteria within the oil glands. Drying out the sebum production essentially starves the bacteria. It's worth pointing out that systemic retinoids are much more effective at this. In fact, the topicals provide relatively little decrease in the oil gland production. This helps to explain why, for acne patients, simply applying Retin-A or Differin has nowhere near the same effect as taking isotretinoin systemically.
A stands for asymmetry. This means that if you were to split the lesion in half, one side would not be equal to the other. Here we can see that if we ran a line through the middle, the top side definitely does not match the bottom. B stands for border. Rather than having a nice smooth border as you see with most benign nevi, melanomas will often have a very irregular or even a notched border. Notice the jagged quality of this particular melanoma's border. C stands for color. Think about what melanoma is. It's a cancer of the melanocytes, which we know from our skin structure and function module are the cells which produce pigment. And what is cancer? Cancer is uncontrolled abnormal growth of a particular cell. So if we have uncontrolled abnormal growth of the pigment cells, it only makes sense that the majority of melanomas are going to exhibit excessive abnormal pigment production. Most of the time we see very dark, exquisitely dark if not black pigment within a melanoma. However, perhaps more diagnostic is simply what is called variegate or mixed color. Notice how dark this lesion is. And while here it's almost pitch black, on this side it's somewhat faded and much lighter in color. Along the border, it's even somewhat pinkish tan, and overall there are varying shades throughout. C can also stand for change, as in constant or ongoing change. Typical benign nevi can and do change over one's lifetime, but such changes are usually very gradual and often in proportion to other moles on the body. When a patient has a melanoma, it's very common for them to report that the lesion was constantly changing, getting larger, darker, showing varying shades of color at different times, sometimes even itching or bleeding. Change is, in fact, the most important warning sign for melanoma, so patients need to know this. In order to make sure this important criteria is addressed, you will find that newer educational material reviewing the ABCDEs of melanoma will either clarify that change is the second C characteristic, or some even add E, as in ABCDEs of melanoma, in which E stands for evolving, which is just another way of saying changing. Regardless of whether it's called changing or evolving, one way or another, just make sure patients are aware of this most important of warning signs. Finally, D stands for diameter. The rule of thumb has been that melanomas generally measure at least 6 millimeters in diameter. The often quoted yardstick for this is the pencil eraser, since they are usually about 6 millimeters across. Please understand that just because a mole simply measures greater than 6 millimeters in diameter, that does not mean that it's a melanoma. Patients will often get confused about this. A size of greater than 6 millimeters is only significant if a lesion otherwise fails the other ABCD criteria.
All layers of the skin lose volume as we grow older, but the subcutaneous tissue is particularly vulnerable. You may have observed that the elderly experience an increased tendency to bruise, especially on the forearms and hands. One of the reasons for this is because the age-related loss of volume results in less cushioning for the blood vessels. Without that protection, these vessels rupture more easily, resulting in those annoying bruises which we refer to as solar purpura. When you see at first glance what appears to be a larger patch, but on close inspection it is elevated above the surface of the skin, you are instead dealing with a plaque rather than a patch. The textbook definition of a plaque would be a solid, plateau-like elevation measuring at least 0.5 centimeters in diameter. In practice, most dermatologists wouldn't use the term plaque until such an elevation of the skin measures at least 1 centimeter in diameter. Psoriasis commonly presents as erythematous and scaling plaques on the elbows and knees. Permoxine, on the other hand, is known to provide some anesthetic or numbing effects, and it's this quality which is thought to help alleviate itching in patients using it. Menthol, camphor, and other irritants work a little differently. In providing either a warming or a cooling sensation on the skin, they essentially override the itch sensation in the skin. The sensation of itching is essentially the result of low-level stimulation of our nerve endings, in the same manner that a fly buzzing around our ears creates a low-level buzzing noise. If the room is quiet, then our ears have only the buzzing fly to focus on, and the average person would find this quite annoying. But if we turn on the radio and raise the volume loud enough, our ears will naturally gravitate to the louder noise and the lower-level buzzing fly is drowned out. Menthol, camphor, and other irritants basically work the same way. In fact, scratching works like this also. By cooling the skin with menthol, warming it with camphor, or even by scratching, we're essentially irritating the skin in a way which overrides the low-level nerve impulse of itching. And indeed, it's the side effects that top the list of what patients should know for either medication. Patients should always be warned about the inevitable redness and irritation that they will experience while using it. They must take work and social commitments into consideration when planning to begin treatment. For example, beginning a full-face treatment of actinic keratoses within the weeks prior to a class or family reunion would not be a good idea. Likewise, if someone works in sales, they may want to consider an alternative treatment option, or wait until they're on vacation to treat, as the redness and inflammation is certainly enough to scare away potential clients and customers. Also, direct prolonged sun exposure of the application sites during treatment should be avoided. In fact, if a patient spends a lot of time outdoors because of work or hobbies, some doctors will recommend waiting until the fall or winter to treat. Having said all of this, it is amazing just how often patients will recount stories of being prescribed such a medication by a physician who never told them that their skin would get inflamed during the course of treatment. To prescribe this type of treatment without warning patients of the side effects is simply inexcusable. Perhaps what happens more often is that a doctor may briefly mention the possibility of redness and irritation, but downplays the significance of it. In our example syringe, each line represents 1 cc. And you likely know this by now, but 1 cc equals 1 milliliter, so these units of measurement are used interchangeably. So let's say we draw in 1 cc of Kenalog 10, which as we just stated, gives us 10 milligrams of Kenalog for every 1 milliliter of solution. In this visual, each of these purple dots represents 1 milligram of Kenalog. In our first dilution, we're drawing in an equal part of sterile water. Because we started with 1 cc of Kenalog, this equal part of water will also be 1 cc. So we draw out to the 2 cc mark. We still have the same 10 milligrams of Kenalog that we had before, but now it's diluted within 2 cc's instead of 1. Remember, 2 cc's equals 2 milliliters. So 10 milligrams divided amongst 2 milliliters gives us a concentration of 5, or 5 milligrams per milliliter. UVB ranges in wavelength from 290 to 320 nanometers. UVB's tendency to impart all of its energy no deeper than the upper dermis is what also makes it the form of ultraviolet light most associated with sunburns. An easy way to remember this is to think of UVB as UV burn. The UVB spectrum is the most harmful light we receive because its energy is easily absorbed by the epidermal skin cells. When UVB imparts its energy into these cells, it can damage our DNA. Something else ultraviolet light does is that it temporarily, though significantly, suppresses our immune system activity within the skin. It's this combination of damaging our DNA, combined with the effect of compromising our immune system's ability to repair this damage, that makes ultraviolet light a leading cause of skin cancer. On the other hand, we sometimes use the immunosuppressive effects of ultraviolet light to our advantage, for conditions such as psoriasis, which essentially results from excess immune activity in our skin. Perhaps more interesting is that even within the spectrum of UVB, different specific wavelengths are associated with different effects. For example, ultraviolet radiation at 311 nanometers is the wavelength which we think of as narrowband UVB, which is used to treat psoriasis as well as a handful of other conditions. It's an interesting wavelength in that it seems to penetrate the skin and impart its energy at just the right area to suppress the inflammation of psoriasis, while being much less likely to burn the skin than full-spectrum UVB.
So how does HPV cause a wart? It starts with an HPV virus particle, which is called a virion. Virions are very small, and upon entering the skin, they make their way to the nucleus of the cell. As you may recall from our skin structure and function module, keratinocytes are created initially in the basal cell layer, and then gradually migrate toward the surface, taking on slightly different characteristics as they mature. Unfortunately, HPV, being the virus that it is, has learned to not only remain within the nucleus of the infected cells as they mature, but has also learned to spread to the surrounding non-infected cells. Once inside the nucleus of these infected keratinocytes, HPV causes the cells to move more rapidly to the surface, causing the proliferation of keratinocytes that we recognize clinically as a wart. HPV also significantly increases the amount of keratin retained within the cells as they migrate toward the surface. This only adds to the thickness so commonly associated with warts. Finally, HPV even stimulates the formation of capillary blood vessels, which tend to thrombose and shear close to the surface, giving the appearance of black dots that patients often refer to as seeds. Actually, that's worth repeating. There are no seeds in warts. It's an illusion, and again is simply caused by newly forming blood vessels within the warts that have essentially formed minute scabs within the wart. Certainly don't argue with a patient if and when they say this, but likewise, we shouldn't perpetuate the myth of seed formation.